Good evening, everybody. Welcome once again to RSSDI Diabetes Brights program, a social initiative from RSSDI. Today, we are entering a 30-second episode of RSSDI Social Bytes program. And the topic chosen for today is improving vision of people living with diabetes. We are all aware that diabetes can affect many people, affect eye and damage vision over the years. To speak about this and to take this topic further, we have a senior physician among us. He's also the chairperson of Telangana State RSSDI, Dr. Mahesh Murtha. He runs a hospital called Premier Hospital in Hyderabad. He's in 40 years of his practice, he's received numerous awards, and he's a physician for the last 40 years, physician diabetologist, who's going to share his experience on diabetes and how to improve vision of people living with diabetes. Along with us, we have our guest, Dr. R. Narayanan. Dr. Narayanan is very passionate about what he does. He's from L.V. Prasad Eye Institute at Hyderabad. He's been with two worlds. He's trained partly, he started teaching. Also, the secretary has been trained here in the US, a clinical investigator in the field of ophthalmology and retinal surgery, vitreoretinal surgery. He's a guest lecturer at many universities in the US and a very active and passionate member. I had the pleasure of discussing companies earlier with him. Welcome, Dr. Narayan, to Social Bytes program in RSSDI. Our viewers shall benefit from your experience. And none other than a close friend of mine, a colleague who just 1 kilometer from where I'm sitting, is our secretary of Karnataka State chapter of RSSDI, a very enthusiastic physician, diabetologist, a marathon runner. He calls envy in all of me because I never move, and he is always moving. That's his better qualification. He loves to be called a marathon runner, always runs 20 to 30 kilometers.
Thank
and
you.
take up that. He's also an MRCP lecturer and examiner from the state of Karnataka. I think we have our President, Dr. Bansi Sabu, joining us for a program. Welcome, Dr. Bansi. And he will be there to introduce all of you. Now, I would stop my introduction, and we have my colleague Amit with me, who's part of the RSSDI Social Initiative or Bytes program, along with Purvi, Dr. Pratap, Shalini, and the whole of RSSDI, our President Bansi and Secretary Sanjay Agarwal. One of them will join in between. With brief introduction, I'm Dr. Sanjay Reddy from the RSSDI EC, requesting Manohar to take over and moderate the program for today. Thank you. Thank you once and all for again accepting our invitation at a short notice.
A big hello from RSSDI, and thank you, Sanjay, for the kind introduction for all of our team.
Hello.
And I'm indebted to Dr. Bansi Sabu Saab, who is our chairman with a lot of ideas. And this is one of the initiatives which was very well appreciated by every person whom we meet. We're reaching out to the public in a great way. And as Sanjay told, we always have great experts in different fields. And today we are talking about the eyes, one of the most important organs in our body. And it has some unique features, isn't it? Dr. Narayan would tell more about it. It's one of the places where we can see the blood vessels easily. So do you want to comment on that and brief about the eyes, vitality, diabetes and eye correlation before we move on to the question?
Yeah, sure. Thank you once again. In fact, thank you for all the audience actually for joining us in these times. I know it's not easy nowadays. While we are far away from each other, I think because of these online tools, we are also getting more and more busy. Thank you to RSSDI President Dr. Bansi Sabu and also Dr. Sanjay Agarwal for this initiative, which is a very, very important initiative. Dr. Manohar, your question, if I can just put it again to our audience, its eye is a window to the entire body for the doctors. So normally, we all know if you want to diagnose something, any problem in the lungs, kidney, pancreas, or anywhere, you need to do a biopsy, meaning you have to cut open the body, take a small part, send it to a lab, And the lab specialist pathologist will probably tell, looking under a microscope, okay, this part or this body is diseased. But looking into the eye, you don't need any biopsy, you don't need to cut open anything. You just look at it through a small instrument, and you can see the retina, and the retina can tell if there is any problem, especially like in patients with diabetes or blood pressure or many other diseases. Just by looking into the eye, a doctor can tell whether the other parts of the body may be affected or not, such as kidney or the brain or the heart. So the eye is a window to the entire body, actually, in a scenario like diabetes or blood pressure. And if there are any blood spots or cholesterol deposits in a patient with diabetes, one can probably imagine that even the kidneys or the heart may have some form of damage due to those diseases. So that's in brief about how useful looking into the eye can be.
Well, thank you. Coming to Dr. Mahesh Marda, sir, you've been practicing for so many years, human service to the society. And how do you think diabetes affects the eyes in what all ways? What are the things which we should take home?
Yeah. It is a very important topic. Good evening, everybody. I'm thankful to Dr. Bansi Sabu for his great initiative. I think with this, common man will be able to know something about the preventive aspects of especially diabetics and hypertensives. If they know about the eye also, a lot of things they can save their eyes. Vision is such an important thing. Unless we supposing anybody doesn't have vision, they only know the importance of it. I see people. We have a blind hostel for the blind beside our hospital, and blind people come to me for treatment, for free treatment and other things. One person brings three people along. With that person also who brings also has only light, just seeing, and he is able to just move about. So the importance of eye is only known only when we suffer from the vision problems or any other. Even small foreign body, supposing it falls in the eye, then only we realize that so important to protect our eyes. So it is such an important topic that in diabetics and in hypertension especially, we are supposed to screen the patients for all diabetic. Once the diabetes is diagnosed, all diabetics, 20% of the diabetics at the time of diagnosis itself are having some or other eye changes, retinopathy changes. And many people go into loss of vision, and this can be easily protected if we have a good screening procedure and protocol properly. And we have to explain them and how often they should get it tested properly. Fundoscope, in my opinion, for all physicians, we should have a fundoscopy should be learned by everyone. I was lucky to know more about fundoscopy because I did ophthalmology for 1 year before joining my MD General Medicine. So I can easily do the fundoscopy and check it. So fundoscopy is a very simple tool, but it has to be done with some patience. We have to dilate the pupils properly and see that. And there is we cannot means it is such an important topic, and it's such an important thing that we have to prevent these eye changes which occur, and we are able to. These changes usually patients will not have any symptoms. Even the vision decrease in vision is very late phenomena in a diabetic person, so they may be missing it. And minor changes in the blood vessels, even the hemorrhage, if they are not in front of the macula, they will not lose the vision also. So it is very important. Yeah, Manohar, anything else?
Dr. Narayanan, we all know that in a sarcastic way, people tell that politics and wars are the commonest cause of loss of vision. Now, I think the number one cause worldwide is diabetes. Apart from this loss of vision, what are the other problems what a diabetic can face with respect to diabetes and its complications relating to the eye?
So one, actually, Dr. Mahesh Mata has briefly touched upon a lot of aspects. While we say vision it becomes blurred in these patients, the biggest challenge with that is loss of independence, which is a huge problem for anybody at any age of life, and also the scare or the fear of going totally blind. Now, there have been studies which have been done in different diseases, and people have been asked to rate their quality of life in different diseases, right from stroke to heart attack to some cancer to vision loss, a blind person. So, blind person's quality of life, people have rated it just next to a bedridden person after a stroke or so. So, it's as good as not having a life. So, in terms of diabetic retinopathy affecting the eye, while we may think of smaller problems, the bigger challenge comes when people start getting scared of losing their independence. That includes driving, reading, even just plain and simple communication nowadays over mobile phone. That's one of the important complaints patients have, that I am not able to see my mobile number just to simply call someone near and dear. So, and then the other problem is of falls. So you are going to the bathroom, you want to do your own activities, you don't want to hold someone's hand to move around inside the house. Fear of fall or actual fall, these are some of the important side effects of losing the vision. Now, it could be because of diabetic retinopathy or any other cause of vision loss can lead to these concerns among the patients. But we have to address each one of them and not just try to treat the eyes by themselves, because we may or may not succeed in completely restoring the eyesight. As Dr. Mahesh pointed out, in diabetic retinopathy, if you actually have a problem, probably you are late coming to the doctor. So while we try to restore the vision, even if we are not able to restore the vision completely, we may have certain other tools of keeping the patient independent and doing their normal daily activities. So these are some of the aspects which we need to consider overall when we see a patient with diabetic retinopathy.
Thanks to both of you. I think apart from that, the risk of infections for diabetics is always high, and around the infections, around the eye soft tissue, lacrimal glands, and also some rare fungal diseases also can be at an increased risk in a person who has diabetes, especially if they are not under control. So directly, indirectly leading to visual problems. And of course, even the cataract, someone says that the risk of accelerated cataract or that difficulty in vision, not retina wise, but also the anterior chamber also can get affected. Thank you, sir. And coming to Dr. Mahesh Marda, sir, when retina or the eyes are affected, do you think we need to also have a wider perspective and look for other complications of diabetes? What is your opinion on that?
Yeah.
And
Yes,
if
yes.
someone's kidney is affected or heart is affected or eye is affected, is it individual or it does affect every part of the body?
Once the complication starts, usually it all end organ complication, all end organs are involved. So once we find any changes of retinopathy in the eye, then it indicates that he is going to means into complications of the kidney and other things also. So in a way, by checking the eye regularly, we are actually checking the kidneys and other things also. Means the eyes, there is no retinopathy, then at least we are sure that he is not going. Albuminuria, supposing in urine, if albuminuria is there, then there are chances of retinopathy will be there. So both are interconnected, all are interconnected, and we have to be very vigilant about all these complications. Usually, especially in young adults, if they suddenly means blood pressure goes undetected and suddenly they come with high blood pressure. Such people are very likely to get eye problems. And others, like when there is fluctuation of blood pressure in preeclampsia, in pregnancy and other things, eye changes occur precipitately. So we have to be more careful in such cases.
Thank you, sir. Dr.
Hypertension and
Narayan, how?
diabetes, hypertension and diabetes is a deadly combination for the eyes also. Yeah.
Okay, noted, sir. Thank you. Dr. Narayan, how often should we get our eyes screened, or what should be the message to our diabetic patients, or even otherwise, without diabetes also, how often should we screen it? And with diabetes, what is the change? And there is type 1 diabetes and type 2 diabetes, at least for the minimal classification. So is there any difference in between these two, and how do we go about it?
Yeah, those are excellent questions, Dr. Manohar. Actually, I would like to just start off with the more common form of diabetes, the type 2 diabetes. You must get the eye screen at the time of diagnosis of diabetes itself. There's nothing like today I have diabetes, I've been diagnosed with it, and after a few months or years later that we should get it. No, as soon as you are diagnosed with diabetes, you must have an eye checkup, because as Dr. Mahesh pointed out, quite a few patients already have diabetic retinopathy when they're diagnosed with diabetes, and that's because of the fact that the diagnosis of diabetes itself is delayed. Many patients have diabetes and they don't know about it, and by the time they're diagnosed with diabetes, it may be a few years down the line. And that's why patients with diabetes should have an immediate screening of the retina. Now, if at the first examination of the eye there is no diabetic retinopathy, if your eyes are seen to be all right, then the next checkup is usually every year. So an annual checkup is what is recommended in patients with diabetes who do not have diabetic retinopathy. But if you already have diabetic retinopathy, then your retina doctor or ophthalmologist will be guiding you how often they would like to see you. Sometimes it may be once in 6 months, sometimes it may be once in 3 to 4 months, depending on the severity of diabetic retinopathy. Coming to type 1 diabetics, that's a slightly different situation. Let's say a younger patient is having diabetes. Typically, what happens is before puberty, if someone is diagnosed with diabetes, they usually behave slightly differently. But after puberty, because of hormonal changes, the diabetic retinopathy can accelerate significantly. But again, overall, I would say that even in type 1 diabetes, while in general we may be able to have some time for checking the diabetic retinopathy, but anyone after puberty, that's after the age of 12 to 14 years, even type 1 diabetics should have their diabetic retinopathy screening. So this is the overall recommendation for diabetic retinopathy. In general, the day you are diagnosed with diabetes, please take an appointment with the ophthalmologist nearby to screen your eyes for diabetic retinopathy.
So why is that important? In the sense, say I am diagnosed of diabetes, but I don't have any vision problem. This is the commonest excuse or the contrary what patient says. मुझे तो सब कुछ अच्छा दिखाई दे रहा है, फिर आंख के डॉक्टर के पास क्यों भेज रहे हो? So what is it? Does it mean that diabetes related eye changes leads to blindness is the only symptom, or are we trying to talk about prevention and things like that? I think you could answer it, Dr. Narayan.
Yeah, so I think it's a brilliant question, actually, Dr. Manohar. This is probably the crux of this entire 1 hour of discussion.
Yes.
That it's like diabetic retinopathy. If a patient doesn't have symptoms, why should a patient go to a doctor? That's typical for many diseases. If you don't have any symptom, why should you be visiting a doctor? But unfortunately, diabetic retinopathy, until the advanced stages, I would say, not even initial stages, until the advanced stages, doesn't cause any symptoms. It doesn't cause pain in the eyes, it doesn't cause redness, it doesn't cause itching or watering. Nothing. You are absolutely fine today, and patient may have very advanced diabetic retinopathy in the eye, that suddenly you may feel all right today and tomorrow you are blind. So that's how diabetic retinopathy doesn't give you time at all. So it's a preventive checkup. But if you already have symptoms, that means, as I said, if you have already have symptoms, it's probably too late at this point of time to recover the eyesight. So diabetic retinopathy can affect the retina or the vision in two forms. One is by bleeding, and one is by swelling of the retina. So in both the diseases, it happens in an advanced stage. But if you come to a ophthalmologist or your eye doctor at the time of screening, if we find that you are in the mild to moderate stage, we may be able to advise you along with your diabetologist or physician a better control plan, so that you are no longer having a sight threatening diabetic retinopathy. So it's like, just as an analogy, I tell patients that if you are sitting in your house in a room enjoying your TV or whatever, and there is fire all around your community or apartment complex, and the fire has even reached your apartment door, you still would not know if you are just closed in your room watching whatever, anything. You still don't realize that the fire has reached your door. So similarly, diabetic retinopathy, it doesn't give you time, it doesn't give you any alarm until and unless you go and visit the eye doctor. You will not know whether there is any fire sitting in your eyes or the body. So you must have a preventive checkup.
I think it's a wonderful explanation. You re-emphasize why we call diabetes as a silent killer or a silent disease. Again, you also told depending on which part of the eye is affected. If it is the main part, the central part, then the vision can be easily affected as the first symptom. But if it is periphery coming down to the central, it could be slow. And also, you re-emphasize that an ounce of prevention is better than tons of treatment, they say. It means you try and see whether we can have any preventive aspect to it. So that was very well said. Thank you, Dr. Narayan. Sir, Dr. Martha, sir, what tests do we recommend? We split this question into two halves. So what general tests all over the body you expect a diabetic to do? And then I think Dr. Narayan will tell what specifically they look at in the eye. So, Martha, sir, so what tests? I'm a diabetic now, and what tests you want me to do yearly, monthly, and then how is it useful?
We, we usually in hospitals we have a diabetic group of tests we do usually. One is apart from your diabetes, hypertension, we have to rule out number one. Then in the test, lipid profile is very important, because if they are increased, all these eye changes can occur more in persons with high lipids. And then kidney functions have to be checked regularly. Eye checkup has to be done regularly. And if he has any blood pressure and other, if he is a smoker and all, then his cardiac checkup also after the age of 65 definitely has to go, even if he doesn't have any symptoms. These are the tests as a protocol we do regularly. Urine routine has to be done. Repeat means a simple urine examination, albumin in the urine can give can indicate a lot of things, early changes in the kidney. So these are the important things which we should check regularly. And a diabetic means he is a friend of the physician. He has to come to the physician whether he has symptoms or not. He has to visit him once in 3 months at least, even if he doesn't have symptoms, even if his sugars are under control. I always advise them to come visit at least once in 3 years. Just like that, we'll talk over. Don't have to pay even fees also, but you have to come. Just meet me and go. That is the advice usually we give. And we have to means very important. Eyes, prevention is the only thing in these cases. So here the regular checkup and screening is very important.
Thank you, sir. So you just try to tell us systematically other system evaluation is equally important, be it the heart, be it the kidney, look at the pressure, look at the cholesterol, and then also request our friend like Dr. Narayanan to ask what else do you see in the eye specifically? Because some of the patients say, no, I just visited, they changed my glasses. Interestingly, I think before we go on to that, change in the power of the glasses, sudden frequent changes also could be an indicator of
Yes.
diagnosis of diabetes many times, or worsening of diabetes sometimes. So there is a diagnostic value about eye examination with respect to that. And I also would reiterate, retina has been clearly evaluated, and most of the guidelines change the fasting glucose values based on retinal changes, isn't it? So most of the guidelines started moving the glucose values lower and lower for diagnosis, mainly based on the retinopathy. So that is the amount of information what the eyes are giving to us, and changing our guidelines based on diabetes also. So, Dr. Narayan, if I come to your clinic being a diabetic, is it, what are you looking at? Are you looking at my power? Are you looking at my retina? What is it, and how often? And there are a lot of recent advances in your specialty. Some things even I find it difficult to understand. So if you can enlighten our audience on what are the advances and what are the basic things you do.
First of all, Dr. Manohar, thank you for coming to my clinic for a checkup, virtually in the sense. That's the toughest thing an eye doctor faces. Patients don't come to the eye doctor, at least for screening. And they do come only once they start facing problems. But what we need to do is have people come to the eye doctor. As I mentioned, I cannot overemphasize a preventive screening for retinopathy. As I've said, if you already have symptoms, probably it's a little bit late. I would also just touch briefly why it has been difficult to get patients with diabetes to an eye doctor. If you go to ABC multi-specialty hospital, you will have a cardiologist, nephrologist, diabetologist, and every other specialist probably on the same floor or a floor above or below. But you will not find an ophthalmologist, or you may find someone in the basement who may not be there at that time when you need one. And every eye center, Netra Chikitsalaya, Drishti Center, and XYZ Eye Institute is a standalone hospital. Far away, that far away doesn't mean that it's 50 or 100 kilometers away. It's probably another building, maybe a few kilometers down. But that is enough to stop a patient from going for the checkup. Let me do it next time because I feel all right. And there starts the problem. The problem is that we are not coordinated. There is some inaccessibility for some reason. It's a mental accessibility that we are talking about.
So
But
you
again,
mean the ophthalmologists are detached from the other specialities, I think.
yeah, something like retinal detachment. We need to be attached to the other doctors, right?
So I agree. I get that vision now, what you're trying to say. Yes.
Yeah. So somehow we need to have, even if, I mean, it's difficult to get a big eye hospital in a multi-specialty hospital, but we can, in today's world of technology, it's possible to integrate anyone with anyone or anything with anything else. And that's where we need to focus on. We are all one unit. We are for the patient. We are not XYZ specialists just to look after my part of the body, but as a whole for the patient. And we'll probably come to it, Dr. Manohar. I'm sure you'll have some questions on that. But going back to the question that you asked, what all checkup do? We definitely check the eye power. As Dr. Manohar said, that if a patient has fluctuating blood sugar, the eye power can vary. And he also mentioned early on in the program, he's very knowledgeable, Dr. Manohar, about the eyes, is that the cataract can also progress fast in patients with uncontrolled diabetes. Other than that, we definitely take a look at the retina, the complete retina, look at the swelling, look at any bleeding tendencies. Is there any threat of blindness? Immediate loss of vision is what we look for. We also have new tools like a CT scan. We have an OCT scan of the retina. We also have angiography, like angiography of the heart. We also have angiography of the eye, which is much simpler. But we have now a very new technology called OCT angiography, where you don't have to do any injection. Just come, it's like a camera. It can tell you what are the blood vessels in the eye. How wonderful it would be to have a coronary angiography without having to go through all the other hassles. But the point Dr. Manohar mentioned, last point, is that he said that he is probably unable to keep pace with the changing technology in the eye. I can tell you that even ophthalmologists are finding it difficult to keep changing up to date with the changing technology in the eye itself. But overall, I would say retina examination, Dr. Mahesh mentioned fundoscopy, or any form of retina examination, just a basic checkup. You don't need scans and angiographies. Just an eye test of checking your vision, reading those lines in, A, B, C, D, E, F, G, who anybody can do it. And also a basic retina checkup is probably the minimum and the most important aspect of diabetic retinopathy screening.
Thank you. I think it is more to do with the ophthalmologist. So I'll be quizzing Dr. Narayanan more than Dr. Mahesh Marda. How reliable are these fundal photographs? Like someone takes the photograph, how much trained it should be? Is it so technical thing? Why I'm trying to tell is, if we do not instill confidence in the patient that this photograph or the report will it be the same caliber of Dr. Narayanan will be reporting or someone else would be reporting, then the person's chances of coming and meeting the retina, because I'm sure with the population we have and with the burden of diabetes and diabetes related eye changes we have, I don't think one person or few people or few specialists can do it. This has to be reaching to the grassroots levels, and we are seeing a lot of incoming technology of simple fundal photographs, which many trials say it is equally reliable. Artificial intelligence, with evolution, we are moving actually away from natural, and everything we like is artificial now. So, except as everything is getting intelligent. So, artificial intelligence, what is its contribution to retinal examinations or the ophthalmological examinations, and how reliable they are?
Yeah, those are great questions. Again, when we talk about retina examination and whether an artificial intelligence or a lab technician can interpret it, those are the questions we are looking at, because you don't have so many ophthalmologists to screen every diabetic patient. Some amount of the burden probably can be shared, needs to be shared by diabetologists and physicians. But again, they are extremely busy. So you can't say that, every patient in a diabetologist clinic needs to undergo a dilated fundus examination. That's again impossible. But we are having improved technology now. The biggest limitation for a fundus examination is dilation of the pupil. Now, if you dilate the pupil, any doctor, whether it's a diabetologist, physician, or even a retina specialist, can do a better job of assessing the retina. Now, considering that dilation takes time and it's may have some side effects if not picked up as prevention, what we need to look at is cameras which can take photographs in an undilated pupil, and that technology is available. They are called non-mydriatic cameras, and especially those which don't rely on flash, a photography flash. They rely on a scanning laser. They give excellent photographs of what we need to know. It may not take the entire retinal photograph, but whatever is required for screening for diabetic retinopathy, those cameras do a good job. Now, the question was, how reliable are they? If you get a good photograph, I would say 90% of the time they are very good, and a retina specialist would be able to match the findings of the camera. But the problem comes when some patients have cataract or the pupil is extremely small, and that's the time when these cameras are not able to give a reliable photograph. Now, even if you look at that situation, that the photograph is not reliable, it is still reliable in about 60% of patients. So what is remaining is 40% of the patients probably need to be referred for a dilated eye checkup. So at least at this point of time, whatever be the status of the camera, at least 50 to 60% of the burden of screening can be completed at a lab level. I'm saying lab level because I don't know if diabetologists can even screen 50% of diabetic patients. But if a lab where every diabetic patient is sent for blood sugar, lipid profile, anemia, whatever test is done, You just sit in front of the camera in the same lab, just in the next station, take a photograph, come out, and you will get the report in 10 minutes or 15 minutes. Your photograph was reliably taken and you are normal. Normal is quite easy and very accurate. The problem comes is when you have a unreliable photograph. But if it's an unreliable photograph, you could still go to the next level and get your eyes checked by an eye doctor. But till that time, everything can be done in the same lab. Now we are talking about coordination between ophthalmologist, a diabetologist, a physician, nephrologist, cardiologist. I would say add in the path lab in there. Just a coordination with the path lab can things make things much so convenient for a patient. Again, as I said, it is the patient at the center. Make it convenient for the patient as a single stop, a single window. They don't have to go to 2-3 different hospitals for different checkup. So overall, I would say that this should be the approach, and probably the diabetologist should be the main drivers, at least till this level, until the overall testing is done. But once you find that there is some problem, then the ophthalmologist can take over.
Excellent perspective. I feel. I think just few minutes back we talked how ophthalmologists are detached from the other specialties. With the technology coming in, we can always make them attached and be the central part. Yeah, out of 10 patients, 1 or 2 patients, you may have to call them to the specialist center itself. But if you're solving 70 to 80% of the people's problems, not necessarily they have a disease, at least you tell them, fine, your eyes looks fine, come back after 1 year. Even that itself is a very, very reassuring. And the people, as you said, they don't want to walk across the building also. But if you say, your eyes are looking a bit doubtful, and you please meet our specialist, that will make our job easy, I think. Yes, Mahesh Marda sir, you want to say something?
No, what I was telling is our role as a physician is we have to suspect that he may be having eye problem, early eye changes. So who are the patients whom we should suspect?
Yes.
Any young patient having sudden spikes of blood pressure, pheochromocytoma, eclampsia, such conditions, we should be more vigilant. And if there are any minor complaints like floaters in the eye or slight difficulty in reading, then we should become more vigilant and send them for these eye checkups. So all diabetics, because vision gets affected very late, and we are likely to miss if we don't check properly. The preventive aspect is very, very important in this particular diabetic retinopathy. Maybe this is the only disease where we can prevent at least vision, and if we are able to at least stop the progress of the disease, we'll be doing a human service to the patient.
For just following it up, can you predict which patient can get into retinopathy problem, or it is not definitely defined like that? So how do I say whether I should visit more often or someone else?
Same thing which I was telling is anybody having high triglycerides, anybody having a family history of any eye changes, then pregnancy, early pregnancy, we should send them for eye checkup once. Diabetics becoming pregnant, then we should be more cautious about them, about their eyes. And anybody having diabetic nephropathy, then if he is starting, then we have to check eyes more often because he's already gone into kidney problem. So similarly, the physicians and the diabetologists should be more vigilant and check. But anyway, there should be a protocol that yearly once eye checkup has to be done. Yes.
So apart from the routine screening, you're trying to emphasize on associated other factors like symptom-wise, if there is any suggestion or presence of kidney disease, heart disease, or someone is a smoker, then
Yes.
definitely we need to be careful and we should suggest to them. So Dr. Narayan, what is the treatment you give it to our patients who have eye diseases related to diabetes? I know there could be multiple types of problems, but if you say, because people talk a lot about lasers and someone is getting injections into it, someone is talking about some growth factors, one part of the eye is removed. So if you can enlighten our general audience, like what are the different modes of treatment, briefly, no need of getting into too much details of it, but definitely what are the methods we employ to treat such cases?
Thanks again for the question. I would say we sincerely wish that patients don't reach the stage where they have to be treated with injections or laser or surgery. Prevention is the best form. Just re-emphasizing that point, just come for a checkup, or even if your diabetologist can check up once in a year, even if your eyes are fine, that's a much better thing than coming to an eye doctor when the problems start. Now, we do have different kinds of treatment. Whenever there is swelling of the retina, we give injections in the eye. And that's a little bit scary when patients think about it. Obviously, anybody would be scared when we say that we will give injection in the eye. uh, it even is a little bit painful initially, but patients, once they get the first injection, they realize that it's not so painful. But again, it's not just pain in the eye, it's very painful to your pockets too. These injections are expensive, and they have to be given repeatedly over many months and years. And as I said earlier, they do not, in general, restore your eyesight completely. So, one of the problems which patients have is after spending so many thousands and lakhs of rupees over months and years, they may think that, I still don't have complete eyesight. But we should remember that these injections are given not just for sometimes recovery of eyesight, but to prevent further damage to your eyesight. So if you don't take these treatments, you will lose more and more vision. So prevention is better than cure. But if there is a situation where there is swelling of the retina, we do give the injections so that you don't lose further vision. Now, the other type of retinopathy or vision loss which can happen is severe bleeding inside the eye. That's called hemorrhage inside the eye. That is tackled mainly by laser uh, in about 3 to 4 sittings, sometimes in 2 sittings, but on average 3 to 4 sittings. And with those lasers, many patients actually improve significantly in terms of not having any loss, any further loss of vision. And we also eliminate any further risk of any further vision loss. So injections and lasers, multiple, and if it's the swelling of the retina, there are multiple injections which have to be given over many years. So those, that in short is the overall treatment that we have for the medical part of diabetic retinopathy, which we call. There is an advanced form, even more advanced form of diabetic retinopathy, where patients may develop retinal detachment. Now, those are extremely complex cases, and they also have nephropathy or kidney damage. They may also have heart problems along with that. And those surgeries are not done in most eye hospitals in India. They are done by very few eye hospitals, very specially trained retina surgeons. So those are very tough cases, but yes, we do have treatment in all forms of diabetic retinopathy, but we must remember that prevention is always any day better than cure.
Well, thank you so much for that insight, taking us through the gamuts of treatment available for it and how people. And ultimately, we come back to the point that prevention is better than cure. Screening is more important, and do not wait for the symptoms to come. And then, once the symptoms are there, or once the problem is recognized, definitely you got to follow what the doctor, ophthalmologist says. But in spite of not having any symptoms, at least an annual check is mandatory. Is what we are trying to tell to the audience. So don't say I don't have symptoms, so I don't want to go to the eye doctor. Don't say that power is checked, so else need to be done, and I can see everything properly. I can see which hero or heroine is there in the TV, or I can read the news, what is the breaking news. So it's all right for me. So, but there is much more to it than it meets the eye. So thank you very much. Mahesh Mardha sir, do you want to add anything else with respect to the diabetes in general, with respect to the eyes?
I only want to say that diabetics really are in a advantageous position. They become more conscious about their health. So when they are checking their sugars regularly, why can't they check once in a year the eyes also? They are usually, most of the educated and patients are very conscious about their health. So I think that we can easily teach them to go for once in a year checkup for the eye also, and they will, most of them will listen. So the crux, the main take-home message from this our discussion is, the doctors have to be more vigilant about their eyes, and we should be able to send the patients in time to the eye specialist. Early changes, if they start and if they can be controlled by the eye specialist by laser and other treatments, their vision can be at least stopped from deterioration. So the patients have also the responsibility of going to the eye specialist once in a year at least, or if not once in a year, at least they should be, with the advice of the diabetologist, they should go to the eye specialist regularly.
Thank you. And Dr. Amit, thanks for joining in. You have any comments to make?
I think we had a very wonderful session, and I would just like to emphasize one fact and share my experience, as told by Dr. Narayanan. अगर डायबिटोलॉजिस्ट या फिजिशियन स्क्रीन करें तो रूट कॉज को बहुत हद तक इट इज पॉसिबल कि वी कैन prevent the onset of diabetic retinopathy, or at least we can detect it at an early phase. For example, I would like to share my own experience. Before setting up the diabetes center, I was on every patient prescription I was writing that please go for screening for diabetic retinopathy, and 5 out of 100 will go to the eye specialist and get their retina done. Most of them will tell doctor we couldn't go, हमें जाना नहीं था, नहीं जाना है. And now the thing is that because the fundus camera is available next to my chamber, and we are able to take the fundus photograph as told by Dr. Narayanan as well, and 80 out of 100 patient will immediately get it done before they go do anything. And what has happened because of that, we are able to pick up many patients in early stages of retinopathy. We may not be in a stage and immediately we ask them to take a opinion of an ophthalmologist, and many people, they are able to save their sight in time. So I think this is a very, very valid point, that screening is the key to the prevention of the diabetic retinopathy. And one more thing is that, sir, diabetic retinopathy we have talked about a lot, and I will request you just to throw a few points on cataract and glaucoma, because they are equally very troublesome for the diabetic patient. So if you just touch upon these points also, then I think the session will be almost complete.
Yeah, thank you. Sure, Dr. Amit. Diabetic patients also are prone to cataract early on in life. Normally, cataract can develop after the age of 65, 70, but diabetic patients do develop it even early on in their 40s, in their 50s. And there's slightly different forms of cataract, not the routine types, and they may slightly be more difficult to operate. But yes, diabetic patients, especially those who have very high sugars, do develop cataract very early in life. And glaucoma also happens in patients with diabetes. Glaucoma is another silent disease. It's a silent killer, Dr. Manor pointed out. Like diabetic retinopathy, glaucoma, you would not be able to make out any symptoms. I think Dr. Manohar had asked one question which was left unanswered. Even if you are not diabetic above the age of 40, you should have an annual checkup, mainly for the reasons of glaucoma also, because it's not associated with diabetes. It can be independent of diabetes also. So glaucoma is another thing which is kind of irreversible. Whatever loss is there due to glaucoma, we can prevent further damage, but it's irreversible. At least some of the damage cannot be reversed. So these are the aspects of overall glaucoma, cataract, retinopathy. But I would just like to conclude with some emphatic points. Don't be scared. Don't be afraid of diabetes. Hit it hard in the early years. It has a metabolic memory. You diabetologists would be knowing very well. You fight this disease hard in the first 3 to 5 years. and the remaining life will be much more easier than the first 3-5 years. If you don't hit it hard, fight back in the initial years, then the struggle will be much more prolonged. We have had, just to come to the point, that don't be scared of it, we have had famous people, prime ministers, cricketers, senior IAS officers, and all walks of life, any other, they have led a completely normal life with diabetes, with diabetic retinopathy also. Just that, please come to the doctor. And I tell most of my patients, don't be afraid of diabetic retinopathy. If you come to me on time, whenever I tell you, I guarantee you, you will never be blind. You will never be blind. But if you try to run away from the disease, it will get back to you. It runs much faster than you can. So never run away from the disease. Fight it back. You can hit back at the disease, and it will never be able to raise its head on you. And the last point I want to make is, we know that if one candle can light many more candles. So in this audience, whoever is listening to us, you are one candle. Please spread the word. Please spread the word about diabetes and diabetic retinopathy. Just doctors talking in a small conference can never be sufficient. Each one of us participating in this meeting has a duty as well as the opportunity to spread this word in their family and educate everyone else. This way, the world will be a much safer place. Thank you.
Beautifully summed up, Dr. Narayan. Dr. Mahesh Martha, you want to have a final comment?
Same thing as Dr. Narayanan says. There is responsibility of not only the doctors, it is responsibility of the people, the patients also. They have to be more responsible towards their health, and they have to go for checkups. They have to listen to the doctor. Only the thing is, they doubt doctors nowadays because of the monetary constraints. Our tests should be more cheaper, and they should be available easily.
Thank you. Dr. Amit, you want to say something in summary before I
I would
conclude?
like to take your comment as well. Before I thank all of you for being here on this RSSDI platform.
Well, it was beautifully summed up and a very good discussion, I must say. Emphasis is not treating diabetes is costlier. Treating diabetes is never costly because of the complications. We re-emphasize that it is a silent disease. Diabetes itself is silent. Diabetes affecting the eye specifically could be silent. So don't wait for the symptoms. An annual screening at least is important. And we re-emphasize how we started with saying that how ophthalmologists are detached from the other specialty, but technology, because we can't grow the ophthalmologists overnight, but technology has come in a big way. And Dr. Amit himself has told that how it has changed his practice. So by adding technology, by adding artificial intelligence, some beautiful cameras, holistic approach is being re-emphasized. Technology is coming to the fore. Screening, we have emphasized not only for retina, but other risk factors. And it's beautifully said that our health is our own responsibility. We can't leave it for others. I always tell my patients, come here and get treated for your own self. Don't come because mother is upset or daughter is upset or father is upset. So it is our own responsibility. And by spreading this awareness, of course, most of this diet, exercise, and lifestyle changes, I always emphasize, are not for people who become diabetic or hypertensive or heart disease. Diet and exercise is for all of us to follow. Diet and exercise should be a school curriculum. It should be a target in our companies. Companies and wherever you work, you may have targets. Why don't we give them health targets? Your weight is 8 kgs more. So the next year, I would like to see you 3-4 kgs less. Your cholesterol is this much. Your A1C is this much. Your pressure is this much, but it has to be here. So you have achieved good targets economically or productive work-wise, but what have you done to your health? I think this should be the question what, as an organization, we should address to the government and make it mandatory. Why don't you ask for health targets? Not having vehicle insurance is a crime, but not having health insurance is not a crime. So come on, I think we should change this perspective, and I would like to thank RSSDI, our parent organization, Bansi Sabu, who has wonderful idea, Amit Saab, and the other panelists for bringing me here, and my good friend Sanjay Reddy, I think, who left because of some technical reason. Thank you very much. It was very fruitful for me. I learned a lot from here.
Thank you, Dr. Manohar. On the behalf of RSSDI, our President Dr. Bansi Sabu and Secretary Dr. Sanjay Agarwal, and the entire RSSDI social media team that includes Dr. Purvi, Dr. Sanjay Reddy, Dr. Pratap, Dr. Neeta, and Dr. Shalini Jaggi, I would like to thank all of you for gracing this RSSDI Diabetes Bytes. I think our viewers has learned a lot from this session, and this session will be watched by many of the people after after the session ends as well, because it will be available for future viewing on RSSDI platforms, on all the social media platforms. Once again, in Hindi, for our Hindi audience, आज हमारे साथ जो भी हमारे एक्सपर्ट्स थे, उन्होंने एक बहुत ही क्लियर मैसेज हमको दिया है कि डायबिटीज के साथ साथ आई डिजीज होना बड़ा कॉमन है. अगर हम नहीं देखेंगे तो अक्सर हमें इस डिजीज के बारे में बहुत एडवांस स्टेज में जाके पता चलता है, और उस स्थिति में हमारी हेल्प करने के लिए हमारे आई स्पेशलिस्ट भी हमारी बहुत ज्यादा मदद नहीं कर पाते हैं, और हमें अक्सर कम विजन के साथ या कई बार ब्लाइंडनेस के साथ भी जीना पड़ता है. तो ये बहुत जरूरी है कि हम अपनी आंखों की देखभाल करें डायबिटीज के साथ साथ. डायबिटीज के डॉक्टर्स जब भी आपको एडवाइस करें कि साल में एक बार आपको रेटिना चेक करना है, तो अपना रेटिना जरूर चेक कराएं, ग्लूकोमा जरूर चेक कराएं, अपने समय समय पर अपनी शुगर को जरूर चेक करें, क्योंकि इसका कोई ड्यूरेशन नहीं है. डायबिटीज की आईज की कॉम्प्लिकेशन किसी भी एज में हो सकती है. इवन विद शॉर्टर ड्यूरेशन ऑफ डायबिटीज यू कैन हैव कॉम्प्लिकेशन इन योर आईज. With that note, I would like to thank all of you again. And dear viewers, we will see you next week with another episode of Diabetes Bytes. Till then, bye-bye. Good night.
Bye-bye. Namaste. Jai Hind.